Welcome to the deep dive. We are jumping into a topic that's, let's just say it's incredibly misunderstood and definitely politically charged right now. Who actually gets health care when they immigrate to the U.S.?
Yeah, it's just a minefield of misinformation, honestly. Our sources, they really highlight the confusion. You've got about half of U.S. adults, and interestingly, about half of immigrant adults, too, who are either unsure or just flat out wrong. They think most immigrants can get federal programs like Medicaid or CHIP right when they arrive.
That gap between what people think and the reality is huge, isn't it? So our mission today really is to cut through all that noise.
Right.
We need to lay out the, frankly, very strict federal eligibility rules. Then we'll look at some surprising data on how much healthcare immigrants actually use and what it costs. It might not be what you expect.
Definitely counterintuitive stuff there.
And then finally, we have to get into the current policy battles, the state actions, and the real threats to coverage that are looming right now. To really get this, you have to see how the federal restrictions and the state efforts to kind of fill the gaps interact.
And it all starts with understanding just how limited things are at the federal level.
Okay, so let's just state the baseline rule. This gets skipped a lot in debates. If you're an undocumented immigrant, you are simply not eligible for the major federally funded health plans, period.
That's right. No Medicaid, no CHIP, no Medicare, and really importantly, no buying subsidized plans on the ACA marketplaces either.
That's the hard line. But, okay, here's where it gets tricky, right? Just being lawfully present isn't enough.
Not at all. You have to be a citizen, or you fall into this very specific group of certain lawfully present immigrants, and even then, you need what's called a qualified immigration status.
Okay, qualified status. So let's say someone gets that. They get a green card, become a lawful permanent resident, an LPR. Are they good to go then?
Well, usually no. That's the kicker. For most people who get that qualified status, like LPRs, they hit this thing called the 5-year waiting period. Some call it the bar.
5 years.
Yep, 5 years after getting that qualified status, before they can even enroll in Medicaid or CHIP.
Wow, 5 years that's a really long time to be without that main safety net, especially if you're older or maybe dealing with health issues. Must cause real problem.
Oh, absolutely. Imagine getting your green card thinking, okay, finally some stability, and then realizing you've got half a decade before you qualify for the same basic help your citizen neighbors might rely on. It's tough.
Is there any silver lining during that wait?
There is. For this specific group, during that 5-year wait, LPRs can go to the ACA marketplace, they can buy a plan there, and they can get the federal subsidies, the tax credits, to help pay for it. So that's a key difference.
Okay, so marketplace access is there, but not Medicaid or CHIP right away. Are there exceptions? Any qualified immigrants who don't have to wait 5 years?
Yes, and these are really important exceptions, often tied to humanitarian reasons. Think refugees, asylees, folks from COFA nations, the Compact of Free Association countries. They generally don't face the 5-year wait.
Okay, that makes sense. But then there's the flip side, people who are here legally but still don't qualify.
Exactly. You have individuals who are definitely lawfully present. Maybe they have temporary protected status, TPS, or they're DACA recipients. But under the current federal rules, they generally aren't considered qualified for Medicaid or CHIP at all.
So even with TPS or DACA, living and working legally, paying taxes, still no eligibility for Medicaid or CHIP generally. It just shows how narrow that federal qualified definition really is.
It's incredibly specific.
Yeah.
And that restrictive environment leads straight into some really interesting, almost paradoxical data when you look at who's actually using the system.
Yeah, tell us about that. The enrollment paradox, you called it.
Right. So you'd think, okay, immigrant families often have lower incomes, so maybe they'd rely more on Medicaid, right?
It seems logical.
But the data shows the opposite. Immigrants under 65 are actually less likely to be on Medicaid or CHIP than U.S.-born citizens. In 2023, it was about 19% for immigrants versus 23% for the U.S.-born.
19 versus 23%.
And even among those immigrants who are eligible and lawfully present, they make up a pretty small share of the total Medicaid CHIP population. Just 6% of enrollees under 65 are eligible non-citizen immigrants.
That completely flies in the face of the narrative you sometimes hear about these programs being overwhelmed, doesn't it?
It really does. And then there's the cost aspect, which is also surprising. KFF research found that immigrants tend to use less health care, and their costs are significantly lower.
How much lower are we talking?
It's pretty stark. On average, the annual healthcare spending per person for immigrants is around $4,875. For U.S.-born citizens, it's about $7,277 citizens.
Wow, so immigrants' costs are roughly 2/3 of U.S.-born citizens. What's behind that big difference? Are they just healthier?
That's part of it, yeah. Immigrants, on average, tend to be younger and healthier, especially when they first arrive. But critically, those lower costs are also tied directly back to the barriers we were just talking about.
Like being uninsured, language issues.
Exactly. Higher uninsured rates, language challenges, and very real fears related to immigration status. All that leads people to delay care or skip preventative stuff altogether. So, ironically, the folks costing the system less are often facing the biggest hurdles to getting care in the first place.
That difference is just so important for understanding the gap between the political talk and the actual economic facts. So the data kind of flips the script. It's not necessarily a drain, maybe even a net contribution.
Well, when you look at the non-emergency system, the numbers strongly suggest that. Research indicates immigrants, and that includes undocumented immigrants, contribute billions every year through tax, income tax, sales tax, property tax, and through insurance premiums they might pay.
So they're paying in.
They're definitely paying in. And this contribution effectively helps subsidize the whole U.S. healthcare system, offsetting costs for everyone, including U.S.-born citizens.
Okay, but we have to talk about the one place where federal Medicaid funds do interact with undocumented individuals, emergency Medicaid. How big a deal is that financially?
Right, emergency Medicaid. It's really the only federal Medicaid spending related to undocumented immigrants or other lawfully present immigrants who aren't eligible for regular Medicaid. And honestly, the spending is minimal.
How minimal?
We're talking less than 1% of total Medicaid spending. Between fiscal years 2017 and 2023, it stayed under 1%. For the last fiscal year, 2023, it was just 0.4%. It's about $3.8 billion.
0.4%. That is tiny compared to the overall budget. And it's not like regular health insurance, is it?
Not at all. It's not comprehensive coverage. It's basically reimbursement to hospitals because they're legally required to provide emergency stabilizing care. And a big chunk of that $3.8 billion, by the way, goes towards things like labor and delivery costs, which are obviously essential, but also expensive emergency services. It's reactive care, not preventative.
So if the federal system basically guarantees only the most expensive kind of care, emergency care, that leaves a huge gap for comprehensive coverage for many immigrants.
A huge gap, a policy black hole, really. And that's where the state started stepping in, seeing that relying only on emergency rooms or making people wait 5 years wasn't working.
So necessity breeds innovation, right?
Yeah.
What can states do using federal funds? Do they have options?
They do have some flexibility with federal money. The main one is using federal options to waive that 5-year waiting period for certain groups, usually vulnerable ones like children and pregnant individuals.
And are states actually doing that?
Oh yeah, quite a few. As of early 2025, you've got 37 states plus D.C. that have used the federal option to cover kids sooner, and 31 states plus D.C. have done it for pregnant individuals. So there's pretty broad agreement on getting those specific groups covered more quickly.
Okay, so that's using existing federal flexibility. But the really interesting part is when states go beyond the federal rules, using only their own money.
That's where you see the major policy shifts. As of April 2025, 14 states plus D.C. decided to provide comprehensive state-funded coverage to kids, regardless of their immigration status, using only state dollars.
14 states for kids. What about adults?
That's been a newer and maybe more politically challenging step. But we now have 7 states, California, Colorado, Illinois, Minnesota, New York, Oregon, and Washington plus D.C. that have expanded fully state-funded coverage to at least some income-eligible adults, again, regardless of their status.
So these states are essentially creating their own coverage programs for these specific populations, paid for entirely by their own taxpayers. That's a big commitment. And does it work? Do we see results?
We absolutely do. The research shows pretty clearly that these state expansions lead to fewer people being uninsured and real improvements in accessing health care. Like when California expanded coverage to undocumented children back in 2016, the uninsurance rate for that group dropped by over a third.
34% drop, that's significant. It shows these policies do connect people to care.
Definitely. When coverage is available, people use it, and uninsurance goes down.
But now, these very state programs, the ones that seem to be working, improving health, reducing uninsurance, they're facing major threats, aren't they? Both federally and sometimes at the state level, too.
Yes. The landscape is shifting, and not necessarily in a good way for these expansions. We're seeing some immediate and pretty severe federal threats emerging.
Like what?
Well, there are provisions baked into the 2025 tax and budget law that are specifically designed to clamp down on federal eligibility. They're set to basically eliminate federally funded coverage for a lot of lawfully present immigrant groups who are currently eligible. Think refugees, asylees, TPS holders.
Wait, so people who are here legally, playing by the rules, have coverage now. They might just lose it because
Yeah.
the federal definition is changing.
That's the projection, yes. The plan is to narrow eligibility mainly to lawful permanent residents, COFA citizens, and maybe a few other very specific groups. The Congressional Budget Office looked at this, and they estimate that this change alone could cause about 1.4 million lawfully present immigrants to lose their health insurance. Just like that.
1.4 million, that's huge. And then there's this other proposal in the House, targeting states for using their own money.
Right. This one is, well, it's pretty aggressive. It's basically designed as a financial penalty to discourage states from funding their own coverage expansions for immigrants, regardless of status.
How would it work?
It proposes cutting the federal Medicaid match rate, the FMAP, Federal Medical Assistance Percentage. For states that use their own funds for these expansions, the proposal is to drop the federal contribution rate from 90% down to 80%. That means the state suddenly has to pick up a much bigger chunk of the cost for all their Medicaid expansion population, not just the immigrants.
Wow. Okay, so it's not just penalizing the specific state program, it's hitting their broader Medicaid funding. That sounds like immense pressure on state budgets. What's the potential financial hit?
The scale is massive.
Mm-hmm.
KFF ran the numbers. They estimate this penalty could shift something like $92 billion in costs from the federal government back onto those states if the states decide to keep their state-funded programs going despite the penalty.
$92 billion.
Yeah. Or if states decide they just can't afford it and scrap those state-funded programs, KFF estimates about 1.9 million people could lose their coverage entirely.
Can you give us an example, like for a specific state?
Sure. Take California, which has the largest expansion. If they kept their program under this proposed penalty, the analysis suggests they could face a hit of around $30 billion because of the reduced FMAP. New York could be looking at something like a $16 billion penalty.
$30 billion for California, 16 for New York. Those numbers just show the kind of leverage this proposal is trying to exert on state choices.
It's clearly designed to make states rethink these policies. And, we don't even need that federal penalty to see states facing pressure. Look at California right now. They're dealing with a big budget deficit, and they're already proposing cuts to their state-funded medical program for undocumented adults.
Really? So even the pioneer state is looking at rollbacks. What are they proposing?
Well, the governor's plan includes freezing new enrollment for low-income adults without legal status starting in 2026. And then, maybe even more significantly, starting in 2027, they're proposing to charge people already in the program a $100 monthly premium.
$100 a month for people who qualified based on low income, that could be prohibitive.
It could definitely be a barrier. The state estimates these moves would save about $5.4 billion by the 2028-2029 fiscal year. It just highlights how vulnerable these state-funded programs can be when state budgets get tight, even without federal interference. #DagOutro.
Okay, so after digging through all of this, the rules, the data, the politics, what are the key things you, the listener, should take away?
I think there are two really crucial points. First, federal coverage for immigrants is just far, far more restricted than most people think. You've got these narrow definitions, these long waiting periods. It's not an open door.
Right, the perception is really off. What's the second takeaway?
The second is that the restrictive policies and just the general political climate create this atmosphere of fear and confusion. And that fear acts as a massive barrier, even for people who are lawfully present and potentially eligible for help. It stops them from seeking essential services.
That fear factor, that really stood out in the data, didn't it? That nearly 1 in 8% of lawfully present immigrants said they avoided applying for help, like healthcare, food, or housing in the past year. Not because they weren't eligible, but because they were afraid of drawing attention to their status or a family member's status.
Exactly. It shows how policies built around restriction don't just affect the targeted group. They can create broader public health issues by making people scared to get help.
Which leads us right into our final thought for you to chew on.
Yeah, so consider this. We've seen that immigrants, including those without full eligibility, generally use less health care, cost the system less per person, and contribute billions economically through taxes and premiums.
Right.
So if that's the case, what are the real long-term costs, both for public health and the economy, of policies that restrict access to basic preventative care? Policies that pretty much guarantee people will end up needing more expensive reactive emergency room treatment down the road because they couldn't get care earlier.
By building these walls around preventative care, are we just setting ourselves up to pay a much higher price in dollars and in health outcomes later on? Something to think about. That's it for this deep dive.